So I am very excited to chat with today's guest. We have Dr. Jessica Drummond, and we are going to talk about endometriosis. It should be a fascinating conversation. Let me dive into Dr. Jessica's impressive bio here. So, Dr. Jessica Drummond is the founder and CEO of the Integrative Women's Health Institute. For over 2 decades, she has worked with women with complex chronic illnesses such as endometriosis, pelvic pain, painful bladder syndrome, and vulvodynia, and has educated practitioners in over 60 countries. She takes a root cause, innovative approach to healing in collaboration with her clients and students. And welcome, Dr. Jessica.
Thank you so much for having me. It's a pleasure to be here.
Yeah, it's a pleasure to have you here as well. Looking forward to talking about endometriosis. And so let's before you explain what endometriosis is for those who are unfamiliar with it, let's go a little bit deeper into your background. So how did you start helping women with endometriosis as well as pelvic pain, painful bladder, syndrome, all these complex chronic illnesses?
Yeah, so became a physical therapist first. I graduated from physical therapy school back in 1999, and I thought I would work in orthopedics and sports medicine, which I did. But within that first year, I became really interested in women's health specialty physical therapy, which at the time was a lot of focus on still an orthopedic approach to things like athletes in pregnancy, or I had one patient who had had breast cancer surgery and then she had shoulder issues. So, and that evolved. And, of course, women's and pelvic health physical therapists still do that kind of work. But we also ended up doing a lot of work around incontinence and pelvic organ prolapse and birth injuries, which are actually surprisingly similar to orthopedic injuries of intense athletics. And my most challenging patient population were those who had chronic pelvic pain, because back at that time in the early 2000s, we didn't have a lot of options for therapies. And so many of our clients were either struggling with opioid addiction, or they had to have like nerve stimulators, surgically implanted. And none of these things worked very well. And our physical therapy tools were also limited. And at that time, in 2003, my oldest daughter was born, and I had what I understand now, being a functional medicine practitioner and clinical nutritionist, is that was probably a reactivation of Epstein-Barr. I had like intense fatigue and what we used to call adrenal burnout. I was just like wiped out, which was really surprising for me because I had been an active, athletic, I was a physical therapist. Now I'm a new mom, and I was just like trashed. So I learned the tools of clinical nutrition and functional nutrition. I eventually went back and got a doctorate in functional nutrition and then was board certified in health coaching. And I really kind of slowed my practice down to start looking at what could be some of the root causes of these chronic pain conditions. And, since they're also hormonally related, as I was working with women's health and menstrual health, and endometriosis has some of that menstrual cyclical relationship to the pain, that if we could, from more of a nutritional biochemistry standpoint, start to have more tools than just opioids and nerve stimulators and pelvic PT, which in some cases were helpful, in some cases were harmful, and in some cases were just not enough. And that's where I really began to subspecialize in more complex chronic pain conditions.
All right. Well, wonderful. Thanks for sharing that background. So let's dive into endometriosis. Endometriosis. For those who are unfamiliar with it, what is it? How common is it?
It's very common. The underlying cause of endometriosis is a combination of genetic predisposition. So 1 in 9 or so female fetuses are born with endometriosis cells, actually pre-birth. And so we know that there is some genetic predisposition. And then there is usually some kind of immune dysregulating trigger. So it's a chronic inflammatory condition. In some cases, there are autoimmune markers that can be elevated. There are a lot of autoimmune comorbidities, Hashimoto's thyroiditis, celiac disease, things of that nature. And then what endometriosis actually is. So it's common in people with uteruses. It's roughly 1 in 9 to 1 in 10 people with uteruses that have endometriosis. And within that, what it is that tissue that is similar to the tissue that lines the uterus, which is called the endometrium, grows outside of the uterus. So by definition, this is a disease that is sort of systemic. And these lesions are often in the pelvic cavity. So like around the ovaries, the fallopian tubes, around the bowel, rectum, bladder, but these lesions can grow anywhere else. So I think of it as a kind of benign cancer. These lesions can grow through the diaphragm, they can grow on the lung, they can be a cause of collapsed lung, they can grow in joints. There's been case studies of endometriosis lesions on the knee, inside of the nose. So they really can be anywhere, but because it was originally found, the original theory was that there was sort of this retrograde menstruation that pushed cells out of the uterus in the wrong direction during the menstrual cycle. And, kind of things would get inflamed from there. We know that's not true because we know these cells now can, be there from birth, but they are similar histologically as the lining of the uterus. But one important thing to note about that is because by definition, these lesions, these little growths that are like cancer but not cancerous, they have their own hormone supply, they create their own blood supply, they kind of hijack the immune system to sustain themselves, but they are by definition outside of the uterus. So hysterectomy is not a treatment for endometriosis. Now, there is a sort of sister condition, if you will, called adenomyosis, which is similar types of lesions on the uterine muscle, so kind of inside the uterus. And so that could in some cases be treated, and that's sort of like the current standard of care is it could be treated by hysterectomy, but endometriosis is not treated by hysterectomy.
And so, from what I understand, based on your explanation, so endometriosis itself is not an autoimmune condition, but it's common for it to be present in other autoimmune conditions. You mentioned Hashimoto's, celiac disease.
Yeah, so we don't really know for sure whether or not endometriosis is autoimmune. It's absolutely inflammatory. It does have some features of autoimmune diseases, but it's sort of like a combination of a disease state that's autoimmune in some cases, maybe all cases, chronic inflammatory, and genetic.
Okay. And then is it something that's commonly misdiagnosed where a woman will be having it for many years before someone finally, hopefully, is able to diagnose it?
Yeah, the standard delay of diagnosis is 12 years. For most women, it presents in pre-puberty, around 8 to 12 years old, as gut issues, actually, as digestive issues, bloating, what's known as endobelly in the endometriosis world, but is really SIBO or SIVO, kind of an overgrowth of bad microbes in the small intestine, is very common with endometriosis. The menstrual pain can present and be irregular, early on and actually at any time. It's not always cyclical pain, but some key red flags are those digestive issues, fatigue, and intense menstrual pain or intense pelvic pain outside of menstruation. And then again, because this disease is systemic, there could also be pain or other symptoms pretty much anywhere in the body. So ideally, the time for diagnosis would be roughly middle school, maybe early high school. But for most women, the true diagnosis. Unfortunately, it's a surgical diagnosis at this point. We don't have any easy blood markers, and it doesn't always show up on imaging. So, the only way to truly diagnose endometriosis is with a skilled laparoscopic surgery, which is another reason why often the complete diagnosis can be delayed. But, and it is even possible to be diagnosed in perimenopause, menopause, or beyond. So it gets complicated because each case can present differently. But yes, unfortunately, often women are misdiagnosed with things like IBS or just SIBO without kind of underlying the endometriosis driver, or just menstrual pain. They're often just kind of brushed off and given hormonal birth control to try to quiet the symptoms, but it is difficult to get good early diagnosis of endo. Even now, that number from the start of my career 25 years ago has only declined about 3 years. So it used to be 15 years to diagnosis. Now it's 12.
Yeah, still a long time. And I didn't
Mhm.
realize the relationship between endometriosis and SIBO.
Mhm.
So if someone gets diagnosed with SIBO and if they have underlying endometriosis, that person might take rifaximin or take herbal antimicrobials, which might temporarily help, but it's not going to resolve the SIBO, it sounds like, unless if the endometriosis is resolved, correct?
Yeah, and that's really challenging. Like I said, it's known as endobelly in the endometriosis community because you're exactly right. The SIBO or SIFO could be treated either from an integrative or a more conventional perspective. And then the problem is, imagine you have little lesions growing on and around anywhere around the small or large intestine. You're going to have motility issues. You're going to have little pockets where the fungal or the bacterial overgrowth can thrive. And that could always remain, even if those lesions are surgically removed, because sometimes you then have little areas of adhesions or, inflammation. So sometimes a combination of really skillful integrative therapy for SIBO and SIFO, including bowel function and gut microbiome, and skilled excision surgery, which is the robotic surgery that removes those lesions like from the root, then you can sometimes sort of eradicate endobelly or SIBO, SIFO in a patient with endometriosis, but it can be difficult. We often have to sort of manage it with things like pelvic or visceral physical therapy, rotational movements, breath work, things that help with motility like ginger and artichoke, and then a kind of occasional, like maybe quarterly or semi-annually, support with those antimicrobial herbs, because a lot of times it won't stick because there's that structural change to the gut.
Yeah, makes sense. And then, I mean, there's some train of thought, maybe that's not the case currently, but I'll let you share your thoughts as far as endometriosis being an estrogen dominance
Mhm.
condition, that problems with estrogen metabolism, could be a factor, or maybe even the main factor in the development of endometriosis. So, what are your thoughts about that?
Well, in 2018, we had a great study out of Belgium that showed that endometriosis lesions, about a fourth of them had estrogen upregulation in the receptors, a fourth had progesterone upregulation, a fourth had both, and a fourth had neither. And the challenge is that multiple kinds of these lesions could be in the same person. So yes, some endometriosis lesions are sort of quote unquote fed by estrogen in the same way that you can have an estrogen provoked or an estrogen fed breast cancer, but only about a quarter of those. So it makes sense as to why some women do well with sort of estrogen suppressive therapies, anything from GnRH agonists to hormonal continuous birth control, to even kind of an integrative approach or a functional approach to really support like reducing estrogen, better metabolizing estrogen. But that's not really the driver of the condition. It's part of the condition. And in some cases, it's actually progesterone that's the problem. and in some cases both, in some cases neither. So I really think of endometriosis as more of a structural immune disorder than hormonal. Depending on the age of the patient, usually if we can optimize the gut microbiome and the immune system, the hormones, we want them kind of to be in balance for the whole system. And we've started having interesting conversations about endometriosis and perimenopause and menopause, because the original thought was like, absolutely avoid giving these women hormone therapies. But there is a conversation, there should be an individualized conversation around using hormone therapies if women have significant menopausal symptoms, because they're not always going to exacerbate the endometriosis. And even if they do, there's sort of a cost benefit analysis of that. And then, as you and I know, we do things like support the liver, support the gut microbiome, support bowel function, support the detox pathways, and it's not necessarily problematic to the endo. So it's not 100% of the time that estrogen suppression or even support of estrogen metabolism will help with endometriosis. It's about 25% of the time. And same thing with adding hormones. Sometimes that's appropriate. Sometimes it will really exacerbate the symptoms. Unfortunately, there's no quick test for that. The only way to know if any given person's lesions have that histology is like after taking the lesions out after surgery and doing histology on them. But by then it doesn't matter because the lesions are out. So we kind of have to do this from a trial and error perspective.
Yeah, that's really interesting. So you said 25% involves progesterone upregulation. So in those cases, at least in some of those cases, giving progesterone might actually exacerbate. But like you said, it's if you're taking a whole body approach, like if someone's only given progesterone, maybe that might be problematic. If you're giving progesterone and doing other things, supporting the liver, supporting gut microbiome, then maybe not. And then with I'm sure you're very familiar with the Dutch test, because this was a few years ago, I think, with the different metabolites. I think I recall during one of their lectures, they were saying that endometriosis commonly characterized by elevated 16-hydroxy metabolites. But based on what you said, maybe in some people that's a pattern, but if someone has perfectly normal metabolites, or if they have elevated 4-hydroxy and their 16-hydroxy looks fine, that you can't use that to rule out endometriosis.
Oh, absolutely not. I mean, it's definitely not a diagnostic test. And I would say I see both. Sometimes I see people with perfectly normal estrogen metabolism, but I actually would say that I would more commonly see 4-hydroxyestrogen because it's an inflammatory condition. But both of those, elevated 16 or elevated 4 could be problematic. For me, looking at a Dutch test in women with endometriosis, the most important and first thing I'm going to look at is actually the cortisol curve, because it's very difficult to help them heal in an environment of autonomic dysregulation. So optimizing nervous system regulation really helps with everything else. And then we do know that some particularly like anti-inflammatory antioxidant supplements, things like quercetin and resveratrol and curcumin, again, in the right people, can be very helpful. So in many women with endometriosis, especially those that have significant pain with their condition, and again, not everyone does. Some people have very silent endometriosis until, they struggle with fertility, or, until they hit perimenopause or menopause. So different things can sort of trigger the disease in different people. But for me, I think more about the immune system than the hormone system, and thinking about how all of these systems interact: the nervous system, immune system, digestive function, and then the gut microbiome.
So you said silent endometriosis. So again, you can't just go by symptoms. But when it comes to symptoms, so you mentioned SIBO, like GI symptoms, bloating, gas, pretty common, and then pelvic pain. So would you say those are the two most common symptoms, the pelvic pain and the GI symptoms?
Yeah, GI symptoms, pelvic pain, menstrual pain. Like if a period is taking a woman or girl out of work or sports, if you have to be in bed one day a month, that's a big red flag. If you need pain medication every single month, that's a big red flag. It's genetic. So if a person's mother struggled with endometriosis or infertility or pelvic pain or menstrual pain, a lot of times the older generation women weren't appropriately diagnosed, especially if they were able to have children. So you kind of look for those red flags of women in the family either not being able to have children or having really painful periods. And that's where it can become a bit of a gaslighting situation because, you have a 9-year-old girl and she's got really painful periods and every woman in her family is just like, oh, this is just how it is for us. Like, it's fine. You'll be fine. So painful periods, painful sex, especially pain with deep penetration. It's common that that's kind of deeper in the cervix and in the connection, posteriorly by the rectum. That's a very common place for endometriosis to grow. So painful sex with penetrative sex is a big red flag. Also with the menstrual pain, like it's beyond pain. It can also be like diaphoresis, like sweating and dizziness. POTS is a common, or any kind of dysautonomia is common with endometriosis. In fact, there are sort of two sets of what we call terrible triplets, common comorbidities in endometriosis. One set is bladder pain. So endometriosis, pain for bladder symptoms. And it's not just pain, it could be urgency, frequency, things like that, because it is common for endometriosis to grow on or around the bladder. And then vulvodynia. So that's pain at the very opening of the vulva. So that is one set. And then the other set is endometriosis with mast cell activation syndrome. So a lot of histamine issues, redness, heat, feeling allergic to everything, can't tolerate a lot of foods. Hives is really common, plus dysautonomia, which might mean that you've been dizzy your whole life. You're a person that like can't skip breakfast, or you're feeling like you're about to pass out, purely, actually diagnosed POTS or other form of dysautonomia. And then hypermobility. So if you're, double jointed, or you went into dance or gymnastics or something like that because you were very flexible, that's a big red flag for that kind of constellation of presentations. MCAS, or histamine issues, dysautonomia, and hypermobility.
Sounds like it could be pretty complex, which I mean falls into your bio. They're dealing with the complex condition, so it's not just endometriosis itself, but again, mast cell activation syndrome is pretty complex, and just so
So most people with endometriosis have like a lot of these things, not just painful periods.
Yeah, that's again, so it's not like a 2 or 3 month process as far as getting their health back. I mean, these people, some of these might take in excess of a year to really get their life back.
Yeah, I would say in an ideal situation, we have about 3 months to get the body optimized, strengthened in terms of nervous system regulation, good digestive function, calm some of the inflammation, and balance the immune system. Then they would have surgery, skilled excision surgery, with someone who specializes in endometriosis and is just really skilled at finding those lesions and cutting them out from the root robotically. And then it's about a 6-week to 6-month acute recovery from the surgery, and about 6 to 24 months for full recovery back to like all activities, no more fatigue, no more or much less pain, fertility more optimized. There's a window of opportunity too post-op where the immune system is more balanced from an autoimmune standpoint, where fertility improves significantly. So there are these windows of opportunity depending on what the person's goal is. Like, are they experiencing pain? Are they experiencing fertility issues? Are they most stressed by their digestive problems? What are kind of their key problem areas? And then we can set up a plan that helps prepare for and recover from surgery. Now, not everyone has to have surgery or chooses to have surgery. It is an elective surgery because the vast majority of the time, endometriosis is not life-threatening. There are some rare cases where it is, such as when it's growing on the lung or, things like that. But the vast majority of the time, it's not life-threatening, but it is dramatically quality of life-threatening, as you would imagine. So, when possible, at least having an assessment by a skilled endometriosis excision surgeon is a good part of the healing experience. But not everyone has to or chooses to have surgery. It depends on a lot of factors.
Okay. And then if someone, let's say someone does choose to go through the surgery. So again, you mentioned like the first 3 months, you're doing things to support, their body, the gut microbiome, the autonomic nervous system, just really just trying to do things to optimize their health. And so if you do that and then they get the surgery and then after that, you're still doing things to optimize their health. I know I think you said it's like 6 months post recovery after the surgery. Is there still a risk of the lesions coming back? I guess it does depend on the skill of the practitioner, which is why you said you want to make sure that they choose someone who knows what they're doing.
Yeah, it depends a lot on the surgeon, but even the best surgeons will tell you that sometimes the lesions come back, either they missed something or something grew back. It's hard to say, but I would say that the surgical techniques have dramatically improved. So when I was first doing this back in, like the early 2000s, it was very common for people to have 16, 20 surgeries, like almost a surgery every year for their entire childbearing years. Now, I would say that the majority of people have 1 to 2 surgeries max in a lifetime, sometimes 3, depending on the complexity of the recovery or if there were multiple organ systems involved or if a general surgeon needed to be called in or whatever. But, it's much, much more common to only need 1 good surgery in a lifetime. Now, depending on where a person lives, that can be challenging to access. In the United States, almost all of the surgeries are out of network. There's not good billing support because of how complicated these surgeries are. It's very difficult to get them covered by insurance. So in the United States, they can be very expensive. And then outside of the United States, there can be long delays to accessing them, in Canada or in the UK where there's socialized medicine. So there's challenges with the surgery, no matter which country you're living in, but it's still worth trying to hold out for a skilled surgeon because, doing kind of another non-skilled surgeon can just sort of set you up for needing more surgeries.
Yeah, it makes sense. So even if someone has to wait a little longer to see a skilled surgeon, it's probably better because seeing one that's not as skilled, maybe you'll get some relief, but there's a greater likelihood that you'll need another surgery, multiple surgeries, where with the skilled surgeon, still no guarantee that you won't need another surgery, but a less likelihood that you will need with the skilled surgeon. So, so does make sense. So if someone, I know you said that a lot of these women have autonomic nervous system dysregulation, the mast cell activation syndrome, hypermobility. I assume some don't have all that going on. So if it is a more, I mean, it's still not a simple case of endometriosis, but I guess if they're not having the autonomic dysregulation and the mast cell activation syndrome, is it not as long of a journey in most cases, would you say, or is it still something where you could expect like a similar process? Or I guess the process would be similar, but I guess just the duration of
the recovery easier.
Exactly.
Yeah. Yes. Although it's interesting, I was just talking on my podcast to one of the top endosurgeons. Her episode's coming out in July or August of this year, and we've both noticed, since almost everyone's been infected with COVID at this point, almost everyone I've talked to, if not everyone I've talked to with endometriosis in the last 4 years post-COVID infection, do have all 3 of those things as well. So it may be just that we're dealing with a new environment now where there's a large pathogen kind of overload. So I'm not sure what we're dealing with now when it comes to endometriosis, but I have very rarely met a simple case in the last few years. Now, that also could be because the work that I do is pretty specialized. And same with her, we often see the most complicated of cases. So it is hard to say. I mean, if I was working in an insurance-based, like hospital-based physical therapy, pelvic rehab practice, there may be occasions where we find a, quote unquote, simpler case of endometriosis. And yes, then I would say, like, let's say there are very visible lesions. They're in the common places. A person has a skilled surgeon. They're eating an anti-inflammatory diet. They're doing a lot of stress management. They already have a healthy heart rate variability. They exercise. Their cycles become more regulated. Maybe they're younger. They're only in their 20s or early 30s. Absolutely, we can see a more simple, complete recovery, which could look like 6 months or so, just with some pelvic floor down regulation. If that person is already doing a lot to take care of their gut microbiome and, balance their immune system, and, they're already a meditator or something like that, then yes, it can be there's a wide range of complexity. And as I said, there are people who do have silent endometriosis who don't even know they have it until they struggle with fertility. So, there absolutely could be people with no symptoms of endometriosis who maybe aren't interested in having children. So, and you can have the genetic predisposition and also not express endometriosis. I had a patient in my practice last year who had an identical twin sister who did not have endometriosis. So there is certainly a wide range of expression for sure.
Yeah, I mean, similar with autoimmune conditions, you could have identical twins, one that has Hashimoto's or another autoimmune condition, and the other identical twin, is perfectly fine. So environment does play a big role. Now,
Mhm.
for someone who chooses not to get the surgery, what other options do they usually look into? Like, could things like visceral manipulation help? Obviously, it's not going to get rid of the lesions completely, but maybe to get some relief. Acupuncture, I imagine some people try.
Yes. Now, there are some nutrients to stabilize the lesions. We know that pycnogenol, for example, can help stabilize lesions. Quercetin is helpful, some of the other anti-inflammatories. But yes, like doing a combination of a nutrient program to support gut microbiome and immune health and lower inflammation in combination with pelvic floor physical therapy, which does have, really strong evidence to support its effectiveness for quality of life and pain management. Pelvic floor physical therapy, including visceral mobilization, including things like craniosacral, which is also helpful for nervous system regulation. All of that can manage. In some cases, again, people completely, don't need surgery. I've seen that happen in some cases. And in other cases, their symptoms are managed enough that they choose not to have surgery. So I had a patient, gosh, probably like 8 or 9, maybe even 10 years ago now. And she was about to have surgery and she decided she wanted to try to get pregnant first, which there's a cost benefit to kind of getting pregnant pre or post surgery, but she decided she would just try to get pregnant. And she did get pregnant and her symptoms were quieted. Sometimes pregnancy, because of its impact on the immune system, can reduce the symptoms a bit temporarily. So she was pregnant, she nursed, she had that one child, and she chose not to have any more children. She was going to have the surgery after that, but she felt like, given everything she had done to really get herself healthy, optimize her fertility, optimize her gut health, that she did have some symptoms, but they felt manageable enough to her that she chose not to have the surgery. She had the one child that she wanted. Her quality of life was okay. And, she just continued to really take care of her health, and she was fine without surgery. And that may change in the future, but at this point, this is what her decision was. And it worked well for her.
All right. No, that's awesome. Now, so one of the questions I was going to ask is, since most of the listeners have a thyroid or autoimmune thyroid condition, the relationship between endometriosis and thyroid health, thyroid autoimmunity. Now, you did kind of earlier mention, a couple of times we spoke about like Hashimoto's being more common in those. So I guess that's one potential relationship. And I guess another one I could think about is, if gut issues are common, and then part of that triad of autoimmunity is that increase in intestinal permeability, which SIBO can potentially
Mhm.
lead to. So potentially that could be a link between autoimmune conditions such as Graves, Hashimoto's. I don't know if you know any other relationships, but I'll throw that
Well, I
out.
would say the only thing is, I agree with you. I think, there's this common autoimmune diseases tend to co-present, right? And endometriosis in many people does have sort of autoimmune factors, things like elevated ANA in some people. And those are the kinds of markers we can measure actually declining post-surgically. So I completely agree with what you're saying. Like, some of these risk factors for both could contribute to people having both at the same time. And then the other thing I would look at is, what is their hypothalamic pituitary adrenal axis? Like, how much neuroinflammation are we dealing with? Because if they're under either emotional stress, just because it's very stressful to live in chronic pain. In fact, we're hosting a viewing of a new movie called Below the Belt, which is about endometriosis, people with endometriosis trying to navigate the healthcare system, which, you do the same kind of thing, right? Complex chronic illness, navigating the healthcare system is horrible. And so that in and of itself is very stressful, which can then impact the thyroid, because you've got the HPA axis out of whack. You've got the brain where the HPT, or the hypothalamic pituitary thyroid axis, originates. So anything that causes neuroinflammation and anything that causes emotional stress, which, a condition where at any moment you can be in really intense pain, that's very stressful, especially when you go to the emergency room and they're kind of like, you're fine, or you're a drug seeker, or whatever. That can certainly contribute to thyroid issues, just dealing with, low grade or high grade chronic stress for 12 years.
All right. Yeah. I mean, that definitely see that in a lot of patients with the dysregulation of the HPA axis, and good point about the neuroinflammation as well. You covered a lot of information. Anything that I should have asked you that I didn't ask you, or anything you want to summarize before we wrap up?
I guess I would just say that if someone is struggling with pelvic pain, even if it's not cyclical, even if it doesn't seem to be related to your estrogen, and especially if you also have digestive issues, because about 90% of people with endometriosis have some kind of digestive issue, ask about it. It's hard to be diagnosed because it is such a vague condition and it has that surgical diagnosis. But especially if there are any genetic clues, it's something to start looking at.
All right. Wonderful. Well, Dr. Jessica, where can people find out more about you?
Yeah, great. Our website is integrativewomenshealthinstitute.com. And we also have the Integrative Women's Health podcast, and our Instagram at Integrative Women's Health. We share a lot of information about endometriosis, perimenopause, menopause, and other women's health conditions. And you can find more about that there.
All right. Awesome. Well, thank you so much. I'm sure everyone learns a lot. I definitely learned some new things related to endometriosis. So, appreciate everything you shared.
Thanks so much for having me. I appreciate it.
Yeah. Thank you.